Thank you very much, Helen, for that beautiful introduction, and it's such an honor to be here for many reasons. One, I grew up around here, and I'm a UCLA alumna, so it's nice to be here from that perspective. But also, I so appreciate the work of Helen and her colleagues here, not just in talking about the importance of integrative health, but studying it, developing an evidence base that really reflects what I believe is the essence of complementary and alternative methods of healing, but also the recognition of how spirituality is such a key part of our lives and part of healing. So today I'm going to talk about tending the holy. What is the care that we provide patients as we accompany them towards their dying? And while much of this I will be talking about in that context, it's really how do we accompany people who are suffering? Maybe not just imminently dying, but how do we accompany people that are suffering? So, not a real patient, but an image of a patient that I took care of when I was a medical student. And I came onto the hospital floor in the morning looking for my patient who was sitting right next to the nurse's station. And she was gone from that room, and I knew she was seriously ill, but back then we didn't use the D word that often. And so I asked the nurses, and they said, well, there's not a lot we can do for her. So they moved her way down the hall to this room that was a ward. So there she was in one bed with 3 empty beds. And I just walked in, I walked in, and I was just stunned by the starkness of the room and her quiet whimpering and her deep suffering. And I sat next to her. I just sat next to her as she cried. I held her hand, and finally she just said, "Thank you for sitting with me." And at that moment, I recognized how important it is that we do that. And yet part of my journey in this, many years, is how do we do that, but how do we teach others to do that as well? And it is something that involves a lot of internal training and development, but also practical tools. So I hope I can walk you through relatively a lot of material, but we'll try to simplify it. How can we begin to teach others? How can we ourselves have that strength to sit there with immense suffering? You will have, Dr. Betty Farrell will be talking about suffering and the goals of numeracy tomorrow morning. Betty is a very dear friend and a mentor and a collaborator. We do many, many things together in terms of our work around this area. But one of the most beautiful quotes in there is that suffering occurs when people feel voiceless. This may occur when the person is mute to give words to their experience or where their screams are unheard. That patient that I saw when I was a student, she could not put words on what was going on, but it was palpable, that deep, intense suffering. Now, we talk a lot about spiritual distress as suffering. I think in our society, when we hear suffering, people think of physical suffering. Maybe emotional if we're lucky, but mostly physical. But actually, there's suffering in all of those domains: physical, emotional, social, and spiritual suffering. And there's been many studies looking at spiritual distress actually being associated with poor healthcare outcomes. So when I teach my medical students and others, even a lot of my palliative care colleagues who, like all of us are in busy health systems. Sometimes we go to what we are, quote, trained in. The doctors thought of us as dealing with the physical, as are the nurses. We need to be thinking if someone is in distress and they say their pain is on a scale of 9 to 10, how much of it is physical, how much of it is emotional, social, and spiritual. So as you can see, it affects many, many different things. Pain, greater pain. Marvin Delgado, a colleague at MD Anderson, who's done a lot of work in this area. Depression, anxiety, emotional well-being, general distress, diminished quality of life, etc. And at the bottom of that slide is request for euthanasia, physician assist in dying. And one of my, issues about this whole area of physician aid in dying is what I'm often told is we can't do anything for existential or spiritual distress. Exactly, but that's not true. We can. Accompaniment, helping people not feel alone, treating their physical symptoms, treating their emotional and social symptoms, being present with them, attending to their spiritual suffering. So in a broad way, not just only around end-of-life care, but there have been many surveys and studies about what patients value in care. And there was one study done for a health policy organization looking at what do patients value in care. What's the number one thing? Being listened to. And yes, that can be understood in many different ways. I don't want to take this medication, listen to me. I know how I want to treat my diabetes, that's one. But it's also listening on a very deep level, particularly in those situations when those screams are not heard, right? When a person can't put words on. Being given time, being treated holistically, again, the biopsychosocial spiritual model, right? Looking at all dimensions of that person's care, including their spiritual. We're not divided into 4 quadrants. We should treat people in a more holistic way. And in that same report, when patients were not listened to, what ended up happening? Higher distress, suffering, not surprising, loss of trust and confidence, lack of compliance, poor health, etc. So a very, very key part is listening skills, and again, not just around end-of-life care, but particularly when people are facing their end of life. So what do we need to listen to? Their patient's story. I am more than my cancer. I am more than Parkinson's. I am more than whatever is the diagnosis. I run a supportive and palliative care clinic in oncology, and what I see most frequently is people becoming their diagnosis, right? So I have a patient with advanced pancreatic cancer. So this is how he introduces to me. Hi, I was just diagnosed with advanced pancreatic cancer. That's who I am. And that's a normal response. But how can we listen to those other stories? How can we integrate those other stories? And in a healthcare system that's mostly focused on prognosis, diagnosis, and physical treatment, that just pushes that diagnosis story. The second is what Ira Bio talked about many years ago and continues to talk about: what matters most. What matters most to that person at that time, in that moment that you're seeing them? Family, God, accomplishments, needing to finish important goals, etc. There are many things that matter most. And that is, again, part of these conversations. And then the suffering, the why me question is probably the most common spiritual diagnosis, where Sir George Henson has often taught me this as a chaplain. Why me? Why is this happening now? And if we get stuck in that why me, it's difficult to move onto any type of healing and spiritual healing at that point. Eric Casal actually challenged, back in 1998, he recognized this. The alleviation of suffering is the warrant of medicine, but it's also a test of adequacy. It is a test that contemporary medicine fails, despite the brilliance of its science and its awesome technological power. And I totally believe that this is true. We continue to be so impressed with technology, which is good, and science. You know, I was a biochemist before I went to medical school. I'm totally in favor of advances in science and medication, etc. But when are we going to address that key issue of suffering? When are we going to say that is as important, if not more important, than some of the other things that our patients present to us? So here's the reality of the clinical setting, though. It's busy. I work in one of these settings. I was on call last week at the hospital. I don't really like going there, except I love the patients. But this kind of setting is hard. It's hard to get, and people will report to me, the resident will call and say, okay, we just have a new consult. This is what they're about. And I say, well, so what's their stories, or what's their family situation? What are their beliefs? Oh, I'm just reading off the chart. I don't know that. And I said, well, let's go ask, right? Let's take that time to sit with a person and find out who they are. So we are all very, very, very busy, and I think we're focused on that. I was just speaking last week at Cedar Sinai, actually, for a chaplain meeting, and the chaplains there raised the issue of their also being pressured with time constraints, metrics, volume of patients that they see. So it used to be that we would say, isn't it great I can refer to a chaplain, they have so much time. They can be present, right? But they're just as busy as we are. And quite frankly, hospitals have way too few board-certified chaplains. There should be enough chaplains to see all patients, right? But they're pressured as well. So all of us are working in that. And yet, interestingly, in the study I believe it was out of healthcare chaplaincy in New York at that time, that the #1 spiritual need in hospital patients is love and belonging, right? Love and belonging and being listened to. And yet, this is what they're coming into, and it's high turnover. So it's a challenge for us. Also, all of the studies around burnout show that all of us need a relationship with our patients. That's what we want. That gives us meaning. And yet we're in those settings where we can't do that. So I want to share a story of my mother. My mother, this is when she was okay, now you're going to cry. That's okay. So my mom, this is when she was in her 20s. She's from Poland, and she escaped from Poland. She was married, had a 1-year-old son, and was able to get out of Poland, through Poland, and ended up in England. And she had a beautiful reunion with her husband, Andrew. Beautiful reunion. They were watching some film, and across the screen would all military personnel return to base. And she says, Andrew, don't go. I have a bad feeling about this, don't go. But it's my duty. It's my duty. So 2 weeks later, a knock on the door, and she finds out that his submarine was sunk and he was killed. So here she is in England with now a 2.5-year-old son. She has no idea what's happening with her family in Poland because there's no connection. They could be dead for all she knows. And she gets extremely depressed and suffering, as you can well imagine. Now, this is my mother telling me this story, and what is it that I remember from that story? This is what the psychiatrist shows her when he sits down with her, Rorschaching. Right? And my mother, I said, Mom, what did you do? And she said, I don't know why he showed me that. It was asking me what kind of image I saw. I was hurting. I was suffering. My husband just died. I'm a single mother. All I wanted to do, I wanted him to listen to me. So I said, what did you do? She goes, I threw it back in his face and I walked out. Strong woman. But at that point, that intensity of her suffering. So I put that up, and I was debating whether to put that up or not, except that many years later, she was here and had a wonderful geriatric psychiatrist who was amazing with her towards the end of her life. He was really able to elicit her stories and help her find peace. Help her find peace. It was amazing. He had a geriatric psychiatry. But I put that up for another reason. Because we all have our ink blot version with patients, don't we? There are times when I'm incredibly busy and I'm stressed and I'm looking at the clock and I'm thinking, how could they have added these 4 extra patients to my schedule today? And I get into my usual complaints that we all can get into. And I'm at my last patient and I'm thinking, okay, this is it. I know I skipped lunch today, but I can make that. I go home for dinner. And there's a tear in the patient's eye. It will be so much easier to turn back to the computer and say, I see you're here for medication refills. Right? It would be easier to do that. I don't think that psychiatrist was a bad person. It was World War II. It was a terrible time of war. Who knows what was going on in his life? And to see a widow with that immense suffering is difficult to bear. You know, and that is what we are challenged with when we are accompanying our patients. When do we resort to something that we're comfortable with, that we're trained in, and are afraid for whatever reason to open up that space? And that's where we need those resources to do this. So one of my favorite quotes is from Henry Nouwen. What is this deep listening about? Listening is much more than allowing another to talk while waiting for a chance to respond. Listening is paying full attention to others and welcoming them into their very beings. The beauty of listening is that those who are listened to start feeling accepted, start taking their words more seriously, and discovering their true selves. Listening is a form of spiritual hospitality by which you invite strangers to be friends, to get to know their inner selves more fully, and even to dare to be silent with you. You had a beautiful quote about how the meditation is being in silence. You know, the more comfortable we can be with that silence, so much can happen. It is so full. So, when we talk about accompanying patients, what do we talk about it in the clinical setting? and this is actually true for all of us in any of our settings, but asking about spiritual issues, and I'll touch a little bit on that in my presentation. Being present and not trying to fix. And that is very challenging, particularly for those of us that are trained to be fixers. The use of reflective listening, commitment to stay on that journey, commitment to stay there, commitment to be with that person in their suffering, to commitment to be there to the end. I took care of a patient who did die of pancreatic cancer. She and her husband were, like he is currently my patient, I took care of both of them. And she was in favor of physician aid in dying. And that was just legalized in DC. So as we got closer to her cancer, she lived a year, she was given 2 months and she lived a little over a year. She says to me, listen, I still need that backup prescription, can you write that for me? Now I had promised to stay with her to the end. She asked me specifically, will you be here? So inside I was conflicted because I couldn't write that prescription, but I promised to be there to the end. So one of my colleagues was able to do that. But we talked about it, and she asked me why I had reservations, and I explained some of the reasons, but particularly the openness to mystery. That in our culture, we want everything boxed up so nicely, including our own dying, that we miss out on the things that might happen when we don't control so much. So I visited her about 3 days before she died at her home. And when I went in, I knew there had been some family conflict. I didn't know the details. But when I went in, I saw the rabbi, I saw her family. Everybody was kind of a somewhat joyous, if you can use that word, encounter. And I remember thinking, that's interesting, because I thought there was a family conflict. I walk into her room and she says to me, Christina, you were right. The rift has been healed. And if I had taken those pills 2 days ago, I don't think it would have been. So that is, that's what accompaniment is. It's commitment, it's struggle. I wasn't comfortable with that notion of knowing, she did have that prescription there, I wasn't comfortable with it, but I figured out a way to honor that request for her because it's legal, etc., but also to be genuine and authentic about myself. So this is what's so important. So how can we do this? I want to share with you a very, very, very dear friend. She died last week, and a teacher. Sister Rosemary Doherty. Some of you may know her, some of you may not. She's quite a well-known person. Anyway, she is a Catholic sister who, I guess about 20, 30 years ago, she began a Zen Buddhist journey and became a sensei, actually, in Buddhism as well. And I met her as we were developing some reflective work with medical students, actually quite a bit before. She's also very well known in spiritual direction, particularly group spiritual direction, has authored 2 books on this. And I'm just going to let you listen to her words, and you'll see why she impacted me and so many.
Tending the holy in the now of diminishment, I brought together some of my work with the dying, including a program companioning the dying, opening fully to living, and spiritual direction, and brought together the whole sense of diminishment being not only mental and physical diminishment, but sometimes spiritual diminishment when we go through changes in our life. And that with each of these kinds of changes, there is a holiness, there's something very good. I hope that I challenge people to notice what their own belief system is. For instance, when somebody has Alzheimer's, can they believe that at the base of this person, underneath all the disease, there is a basic goodness and wholeness that they will bring themselves, that they will eventually grow back into, or once the Alzheimer's disease is finished in them, that goodness is still there. And what is it, how is it that we can companion others and ourselves in a way that allows us really to tend the holy, not to fix, not to try to make better, but to be there as companion. The poem by Stephen Garnis Holmes is extremely helpful in that. This is how you loved me, where he talks about companioning without trying to fix, loving in such a way that that you're able to be with the person just as they are. I compared it a little bit to the program Companioning the Dying, Opening Fully to Living, which was inspired by an elderly Catholic priest who found his calling within his diminishment. And he finally said to me one day, I don't know what a priest should do anymore. I don't know the right words, but I can be here companioning, and maybe that's my final vocation. And I realized that this man was teaching me something about the sacrament of presence, but I couldn't have learned any other way, and I wanted to be able to do that for other people also. I'm trying to think of what else might be important for the what I offered.
So the sacrament of presence, the sacrament of presence, and how she so beautifully, not only did she talk about it in these words, she lived it, she exuded that in all of her work, and clearly has impacted so many people, myself included. Shortly before she died, I visited her, and I told her how incredibly important her work was, how it has affected so many, many people, and promised that I would talk about it. And in typical Rosemary way, she just smiled and shrugged her shoulders. Because for her, it's the gift that we have in the moment. What can we do for others? What can we be ourselves? How can we be authentic? So thank you for allowing me to share this about Rosemary. She has, since then, I have realized just the number of people that she has taught in the sense of bringing our presence. And Rosemary did that. When we were developing the reflection rounds that I will talk about, I really sat there and I was a co-leader, but really she was the leader. And in looking how she could just sit in that silence and look at a person's eyes and let them tell their story and be there in that moment and not struggle and not try to look at the clock and not have an outcome, that invited that deep sharing with the medical students. That invited their own authenticity. So how do we tend the holy? When she talks about tending the holy, how do we tend the holy? Well, addressing spiritual issues in clinical practice is absolutely critical. And I will share a little bit how that's done and some models that have been developed to do that. It is often in my own practice, and maybe because I'm a doctor and not a chaplain, that when I open up with a visit, most patients will still think my conversation with her as a doctor is going to be around my physical pain or my physical issues with medications. They may not think, unless they know me, but they may not think that they can bring up spiritual issues. Same in a hospital. Patients are very impacted by the environment and by the setting. So and patients will tell me this, I just don't think that I can bring these things up. That is why everybody on the team needs to address spiritual issues. All of us need to open up that conversations with our patients. All of us need to be there for them, because it's frequently out of those questions that issues of deep suffering, of meaning, purpose come up. And then the second is the practice of compassionate presence, which Rosemary talked about a little bit. So in clinical care, there was some question about how many atheists there are in the room, etc. The definition, and this is from a globe, we've done multiple consensus conferences. The first was Betty Farrell here in California for the US, and this was done in Geneva, Switzerland. We had 43 countries represented. And the point of this definition is that it's broad and very inclusive. So it's that dynamic and intrinsic aspect of humanity through which persons seek ultimate meaning, purpose, and transcendence. You know, how do people find that sense of meaning that that purpose in their life, but also that sense of what is outside of perhaps deep within them, transcendence. And experience relationship to self, family, others, community, society, nature, and the significant of herself. It is expressed through beliefs, values, traditions, or practices. So everyone has that sense of meaning and purpose. I will tell you that spirituality can be a tough word. A lot of people, depending on different cultures that you're in, will recoil because of whatever experiences they may have had as a young person or culturally. If a religion has a lot of political influence or is used for political influences, that gets tied up. But that's not the spirituality of the religion. Intrinsic religiosity is different. So trying, I really, when people say, why don't you use something like meaning? Well, meaning also has many different definitions. And I feel it's important that we talk about spirituality. Spirituality is beautiful. When we think about the spirit, the name of this conference, that inner spirit within us, and encourage people to try to assign what that means to themselves. And maybe something you can even do this weekend is, what is spirituality for you? What is it in your life? Rosemary, another really interesting thing about her was, I asked her about her Buddhist journey, and she said, and she's a Catholic nun, she has incredible theological training. But what she said is she had to encounter the Buddha to understand this. So we all approach these things through our whatever our own experiences are, our own spiritualities. Erica Saul had a beautiful definition, and I think I perhaps used this slide because I had a very different image of him in terms of understanding spirituality. But he talks about that transcendent dimension. Everyone is a transcendent dimension, a light of the spirit. The quality of being greater and more lasting than an individual life gives this aspect of the person its timeless dimension. The profession of medicine appears to ignore the human spirit. And he goes on to say, when I see patients in nursing homes who become only bodies, I wonder whether it is not their transcendent dimension that they lost. So finding meaning in the midst of suffering. Some religions, my own included, say, suffering is good for you. No, nobody says that. The religion doesn't say that. I don't know how people interpret that. But suffering may be seen as an opportunity by some people. And some people may not see it that way. But how can we, regardless of what it is, suffering is what it is. That's what we're handed. And we can't change that. So what do we do with that? And how do we live with that? How do we experience that? So some people can find meaning in terms of learning wisdom or some deeper spiritual exploration. Other people, something is too intense. I doubt, and having shared that story with my mother many years, she told me that story and then some. It took her a long time before she could move through that suffering and that loss. A long time. I think probably when I saw her really integrate was when she was about 92, about a year before she died. It takes a long time sometimes, but it is a part of us. It is who we are. So in a somewhat reductionistic way, how do we in the clinical setting do this when we encounter the person in the middle who is suffering? My mother, who is probably immense suffering that she presented with a psychiatrist. Rosemary, who died of Parkinson's, and when this, that was 2014 when that was done. So she suffered from a long time. Her brother had a terrible experience with Parkinson's, and her sister as well. So, her journey of telling me I have Parkinson's and I'm not going to let this be my brother's Parkinson's, it's mine, and I'm more than my Parkinson's. But it took her a long time to be able to deal with that, as wise and as experienced as she is. We all are challenged with this. But some people have their own resources. And I don't want to say that that's not an outcome. Please, this is not like this is our outcome growth grade checklist. That's not what this is. But just pictorially, some people have the resources where they can move through that, maybe with their loved ones, maybe spiritual directors, maybe others. But some people cannot at that moment as we're treating them. And they may be stuck, they may be suffering immensely. And that's what may turn into what we call spiritual distress. And again, some of us have done that for the purpose of making sure that suffering gets addressed in a clinical setting. And as one of my colleagues at our annual Assisi retreat, a surgeon got into a little fight with the chaplain when the chaplain said, you can't medicalize suffering, you can't call it a diagnosis. And she said, well, that's what we do. We do that, and if we don't look at this as a diagnosis, we're going to ignore it, and then the person will suffer more. Again, some guidelines that are, again, developed with Betty Farrell here, and George Hanzo was part of that, and many others, building on the National Consensus Project. And the Domain 5 was spiritual, religious, and existential aspects. This is the new version that just came out. I believe it's the 4th. And this one includes all of those recommendations from that consensus conference. So I would recommend this as a great resource for you to look at the clinical aspect of how do we address spiritual, religious, and existential aspects in care. But basically that model is assessment, diagnosis, and treatment of distress, identification of the resources of spiritual resources of strength, a generalist specialist model. We're all the generalists, the chaplains, the board certified chaplains are the spiritual care professionals and specialists, provision of compassionate care, being present, and then training commensurate to that. So everybody on the team addresses suffering, provides support. Those of us that do treatment plans, assessment treatment plans, we do a spiritual history. The certified chaplains are the experts, and they do a more detailed spiritual assessment. Now, this is sort of in your classical medical team. Now that we're doing work globally and chaplains aren't present all over the world, I am counting others who may also be providing spiritual care. But I always, suggest that we look at the training, et cetera. But there are many, many, many wise people who are trained in spiritual care. Spiritual directors are one of them, depending, pastoral counselors and others have some training. So there's a cadre of people that could work with us to help. But often what I hear, again, from my nurses and doctor colleagues and others is, what am I going to do if I uncover spiritual distress? It's better if I don't do that because there's no chaplain around. That person will continue to suffer. So what is it that all of us in this room can do? And that is be present. All of us can be present. We can listen deeply. We're not going to be able to fix someone's suffering, but giving them that heart, listening with the heart. Rosemary, when she taught us how to do this kind of reflective listening, she says the question should not come up from here. You're listening to that person's story, and if you're thinking, okay, this sounds like this medical student is having problems with this patient in the ward, so they probably could have broken the news, but then you're not really listening to them. But if you fully listen to that story about what that student felt about that patient, the question to ask that can help that person go deeper in spiritual integration is one that would come from our hearts, is what Rosemary told me. I'm only going to show this one study, and that's Betty's study, to show that there are some studies now, controlled studies, looking at the effectiveness of this interdisciplinary model of palliative care with regard to spirituality. This was done over here at City of Hope and part of a larger NIH grant. And she looked at patients with lung cancer and studied the effectiveness of a palliative care intervention. Patients had 4 educational sessions, and the experimental group had 1 on the spiritual domain. She also did this for family caregivers. And what she found out was less depression, less anxiety as a result of that intervention over the control group, improved spiritual well-being, and improved patient experience. There have been similar studies to this since then in chronic pain management as well. I mentioned those spiritual distress diagnoses that come out of the National Cancer Comprehensive Network. George Hanzo was involved with that as well. They were called chaplaincy diagnoses in that document, and we've since broadened that to spiritual diagnoses. And I do have some V codes that I can code for, the thing that we have to do in the chart around spiritual distress. It doesn't get into some of these. But the point of this slide is to look, it's not just about religion, right? So there's existential, meaning, purpose, lack thereof, abandonment by God or others, anger at God or others that are important to that person. Concern about deepening the relationship with the transcendent, not necessarily theistic, conflicted belief systems, and then despair, hopelessness, grief, or loss, etc. There have been many studies such as this to look at patient spiritual needs, and this one comes out of Iran. And they categorize the patient needs into connection, meaning, and connection, peace, meaning, and purpose, and transcendence. So I put together a chart. I have to show this one first because I borrowed it from my colleague at Children's Hospital, Kathleen Ennis-Dirksen, who's a chaplain. And what she did is she took the spiritual strains, spiritual needs of children, which include love, faith, hope, integrity, beauty as strengths. And then she outlined what those strengths would be and how does she do chaplaincy with a 6-month-old abused child? How does she do chaplaincy with a 3-year-old, etc.? So love, affection, relationship. What is the stress that she identifies? Loneliness, withdrawal, anger, betrayal, apathy. I think this is a very, very, to me, a fuller way of understanding this than that simple distress diagnosis. So hope, the vision, meaning, purpose, despair, disappointment, meaninglessness, helplessness would be the distress. And so I borrowed that a little bit for the adults, looking at the needs of connection, peace, meaning, purpose, and transcendence, the strength being love and belonging, connection to the sacred, and the distress, grief, loss, bereavement, isolation, and so on down the line. And I'm happy to share these with you. I'm just going to do a very quick story, which is about a mother and her daughter. And so Sophie's 44, end-stage ovarian cancer, and her daughter's 13. 7.5 years after many surgeries, she's with chemotherapy with good outcomes. She's now hospitalized, small bowel obstruction, and the surgeon tells her that at this point they can do no more surgery. That's no longer an option for her. And as you can imagine, many issues come up for her, and one of them is, I need to live long enough to see my daughter graduate from high school. To set her on her way, is what she said. She denies depression. She still feels hopeful about her daughter's future, but she feels that deep pain in her soul when she thinks about not being there for her. Spiritually raised Jewish, found meaning in nature, family, and a fight for the cure. She's already lived longer than they predicted, and she's wondering why. Why is this happening to me now? Rachel is too young to lose her mother. So what do you think would be the spiritual distress here for Sophie? Any ideas? What are some of the spiritual issues that she's dealing with? Yes? My me, sort of that existential meaning, purpose, I'm there as a mom, exactly. Yes? Yes, exactly. I fought so hard for her, can't I do another couple more years?
I was just going to ask if you could repeat the answers.
Oh, sorry, okay. So, why me, struggling to be there for her daughter, and then guilt that maybe she's not there for her daughter. Yes?
It's not fair.
It's not fair. And it's not fair. Now, the nurse observes that her daughter is also quiet and extremely anxious. She worries a lot about her mother and what will happen to her. She feels like she cannot do anything to help her. That sense of helplessness. She tells the nurse that she's still playing the piano and it helps her, doing rituals in nature with her mother by bringing pictures of the sunrise, and they meditate together, and she's very grateful for her family. Is there any spiritual distress here? Going back to the pediatrics. Maybe that sense of helplessness, right? Hope. I can't do anything. Right? Okay. So just very briefly, because I really would like to move now more into the presence, is just to talk about the spiritual history. So it's comprehensive, as I mentioned, and it's done by those of us that are developing treatment plans. Spiritual history, I advocate that it should be done as part of every history, part of the social history, but it can also be done in a particular visit where you're breaking bad news. So if you're breaking bad news or having a difficult time, so for example with Sophie is kind of a conglomerate of many patients of mine, and the real person that I was doing this with, and I knew much about her spirituality, but as she was crying and saying, this isn't fair, this is not right. just going back to her spirituality. Tell me where your spirit is now, after a long time of being present and listening, and her being able to talk about what that meant, and her fight, and what her hopes for her daughter were, and talk more about what that meant to her. So this is the tool, the FACP tool. This is available online, and you don't have to write all this down. This is available, but the idea is that this is not a checklist. So I understand it's in all sorts of electronic health records, and I just, after many years of trying Epic to show me what it is, I had an insider who finally showed me what it is, and it's exactly what it's not supposed to be. I just know. Are you spiritual? Yes. And that is not what this is about. So I have a whole new challenge now, but anyway. So the opening, it's an opening question, and I would be sensitive to who it is that's sitting in front of you, have that awareness. So I usually say, is spirituality something important to you? If it's a particular visit, like Breaking Bad News, as I said, I would contextualize it in that this is really hard. Is spirituality something that is helping you in this? So always be very patient-centered about this. If it's, I have many young patients, so if it's a well visit or stressed out, does spirituality help you with stress? So you contextualize it. You see where your patient is. If someone's really, really suffering, I'm probably not going to ask these questions for a long time. I'm going to be present at that moment. If patients might say, I'm not really spiritual, is it religion? Then I say, no, it can be broader than that. What do you understand of that word? Most these days, most people understand that. But sometimes not, and the second question, regardless of whether they say they're spiritual or not, is what gives your life meaning? And then I's importance and influence and how they care for themselves. I usually can hear that in the conversation. Sometimes I ask. And then communities, being part of the spiritual community, church, temple, mosque, like-minded friends, the yoga group. There's many types of communities that people can experience. I actually just had a sort of a conversation with my neighbor whose husband died. She's 92, he was 96. And so I was asking, she's getting a little bit better with it, but it's obviously very hard. So I said, tell me about your communities. And she goes, well, right here, we're in a condo. She goes, I love this community. But then she identified others as well. A Chinese American community, the Kennedy Center, the arts community. So that, and talking about that was good for her. She said, it's good for me to think about the immense support I have. And then A is address and care, but it's also, if in these conversations we identify spiritual distress, we would write that in that part. So it's address and also assessment. Also writing your plan for what you're going to do. So this tool was validated in cancer patients here at City of Hope with Tammy Horniman, Betty Farrell, and myself. And also Ann Berger, who heads palliative care at the NIH, did a quality improvement project where she trained palliative care fellows with the FICA histories. When she trained them alone, there was a little bit of an increase in using it. So next go around, she actually did it together with the chaplains. And the chaplains went in with the fellows as they practiced with the patients. And then they found that the number of histories completed doubled, as did the number of referrals to chaplains. We teach this in a way to look at how, once you have this information, it's important that we ask about all of these domains of care. And one of the reasons I get frustrated in the hospital is when I read the notes, I only see the first one. I only see the physical. I don't see anything about emotional, social, or spiritual. So it's looking at a whole person plan of care. And even if you just touched upon a spiritual diagnosis, even if you just touched on it, just write what you think is being done, and the chaplain will come and confirm or expand, etc. Okay, building on all of this, Dr. Betty Farrell and I collaborated to develop a train the trainer program called ISPEC, Interprofessional Spiritual Care Education Program. We had our first cohort last year in DC, and we have one coming up this summer in Hawaii, because we're collaborating with a chaplain there on the floor. And what this program is three-part, actually. One is an online curriculum, sort of a level 1 WHO course. So we have a 6-module online curriculum that is available. Then there's the train the trainer, where we invited chaplain clinician pairs to come and learn leadership skills on how to use that online curriculum to create culture change in their hospital settings. And we're beginning to work with institutions to actually have institutions develop ISPAC in their curriculum. I want to just share very briefly some of the goals of our first cohorts. We had 52 pairs at the first meeting. So one is implementing spiritual care champions program that would empower physicians, residents, and other social workers, clinical managers to be first responders to the spiritual concerns of patients and families. Very creative. And they're in the middle of this now. There's a 1 year, we continue to follow up for 1 year with the sites to help them with their goals. Another is doing a pilot study to look at the feasibility and acceptability of this ISPEC program to improve spiritual care of patients in pediatric hemonc. Another person is doing something called Rounding with the Chaplain, spirituality training for respiratory therapy, PT, OT, and PA students. Very creative, right? Integrating compassionate presence. So two sites are doing something in presence. Designing a spiritual care database, tracking the number and sources of chaplain referrals, kinds of distress that's being identified, the types of interventions and measures of spiritual care outcome, and then establishing monthly education sessions. Many success stories, people being asked to do grand rounds, being acknowledged for their work by senior members of the hospital. In Kenya, we have people from other countries as well. In Kenya, the Hospice and Palliative Care Association hosted a meeting that brought together about 300 people. And during that conference, there was a 3-hour workshop using some of the materials of ISPEC. Very well received by participants. We're going to be going out to an APCA meeting, African Palliative Care Association meeting this year. Based on the success. Another team supported a very prestigious grant. They just got the grant award for looking at the feasibility and acceptability of spiritual care. Invitation to speak in network conferences. ISPEC curriculum delivered to more than 300 medical students and faculty at Western University. I am pleased to say this curriculum was extremely well received by not only our students, but even comments from our faculty and staff have been extremely positive from the associate dean. But I think what was one of the most meaningful things was this story from one of our participants at Northwestern. 70-year-old longtime patient in the advanced COPD clinic at the VA. He's a retired labor organizer, and he has amazing stories to tell about that part of his life. And he talked about the whole team, saw him today in the hospital, where he slowly recovered from pneumonia and COPD exacerbation. As he was talking to my colleague, he said, "I've gone too far to quit." A little while later in our meeting together, I was talking to him and referred to that expression. What do you mean by that? It led us to an amazing conversation about religion, spirituality, coping, and stress. He told us God doesn't want people to quit, and told us of how his work in the labor, as a labor representative, he had developed the negotiator's prayer that he would say each morning driving to work. It involved, among other things, not quitting. He told us of the importance of his church to his grandparents and parents and him. And then here was the most remarkable part of it. He told us, life is good, people are good, God is good, you just have to take time to look. Isn't that what Rosemary said? Isn't that what Rosemary said? That life is good. Whether people are ill or not, life is good. I mean, what an amazing thing. So he talked about how obvious the source of strength was, and in the end he said, at the same time, the equanimity and peace that I heard and saw in his words, hard to convey by email, was amazing to see. A privilege to get to see and hear these things. It is a privilege to open up to these conversations. Okay. I'm now going to finish just very briefly with the practice of presence in clinical care. And I do believe that it's possible to integrate it. I do agree that's incredibly challenging. But it is something that I've been very committed to because I'd rather have people exposed to it and begin to attempt it. Because you know what happens once you're present with one person and then another. You begin to see the richness of that kind of interaction. And I believe that it happens. I'm just going to share, this is out of our online course, we had to come up with a question on presence. And this is a woman who's 42, diagnosed with breast cancer. Her PG estrogen receptor positive, a pretty decent prognosis. She's getting chemo. She shares that she's doing well, hair loss, wearing a wig, minimal nausea, vomiting, overall feeling good, decent energy. She did talk a lot about the traffic being challenging today. It bothered her more than usual. She's overall hopeful that she will do well. Her oncologist says she has a good prognosis. She does think more about how she might be remembered by her children, and she says she has a very supportive husband. So how would you identify the best response to her using that contemplative listening and presence notion that we're about to talk about? And then they have to identify the best answer. So I piloted this question with my students and residents, and most people said your prognosis is very good. The whole team expects a great outcome. A couple people said, yeah, I had bad traffic. I thought the traffic was awful. I felt terrible, right? The identification. I'm sure you can count on your husband. Isn't that wonderful you have such a supportive husband? I myself have done that in another, not quite this kind of situation. The things we say right when we're on one level of communication. But we're on another level of communication. When you said you want to be remembered by your children, you got a little tearful. Can you tell me more about that? So it's our willingness, it's courageous to do this. It's our willingness to open up into something that we may feel we're not necessarily trained to do. So I mentioned Rosemary teaching us how to do reflection rounds. And we did a program with 18 medical schools, and now we're doing it with residents as well, called GTRR, Jewish Temples and Reflection Rounds. And it's a program for clinicians, faculties, and most of our schools that have done this have continued in their institutions. But it came out of a program, and UCLA was one of the participants in this program, on developing competencies in spirituality and health education. And these competencies, we wanted to frame them in what are called the ACG competencies, which guide residency education and therefore filter down to medical school. Everything there is an official competency except compassionate presence. That was not one of their competencies. But as we did this 3-day cafe model, very, very intense, in a good way, very deep conversations, what should be these competencies? And when we got to this notion of deep listening, people said, okay, patient care, well, communication, well, certainly personal professional balance. So we decided to create its own competency, and these are just some of the elements of that. Awareness of call, spirituality and transformation, the practice of contemplative listening, and seeing our work as a spiritual or a sacred practice. So going just into contemplative listening, which is what I'm going to focus on, not the others, this is what this group came up with. Practice deep listening, hearing what is communicated between words, right? Curious inquiry, a non-judgmental practice of exploration. That's what I saw Rosemary do all the time as I watched her in awe with the students. Very little asking, very little questioning, but very curious, very interested in what was beneath all those words. Practice perceptive reflections. I'm going to say a question coming from our hearts. Use appropriate nonverbal signals to demonstrate interest in the patient. I have a little bit of trouble with that with too much nodding, which I'm a big nodder. You have to be really careful with that, but appropriate. We can all work on that. Demonstrate the use of silence. So this is very hard for people. Very hard. My collaborator, Jim Blatt, who developed this with me, says, it's interesting because he's a high introvert and I'm much more of an extrovert, and yet he can't stand silence, right? He's like, I would think he would be really good with it. It's hard. It's hard, and assessing spiritual issues. So Evers wrote a book. He's, I believe, in Holland. He wrote a book called an article on contemplative listening. He says it's a discussion technique that facilitates persons' internal dialogue, reflective inquiry to help patients focus deeper on their own internal narrative. The primary focus is on how people talk about themselves, regardless of their spiritual, religious, or philosophical beliefs. It involves focusing attention on the imaginary center. And I really love that. Focusing attention on the imaginary center, where everything that the client, patient is, everything that happens to them, everything that motivates them is connected. And our being able to be present and skilled in this, and this takes training, that's why our reflection rounds has a train-the-trainer component, and Rosemary was our initial trainer, and then when she was diagnosed with Parkinson, the people she trained are now working with us. It takes training to do this. It's challenging, but when you can do it, it opens up so much. And the aspects is the patient is the expert, or the student or the client is the expert. We're non-judgmental, non-invasive. All the space is taken up by the person. They use all their points of view, and they personalize what they've shared. So there's no right answer. It's right by what the patient says. As I said, we piloted this in 17 medical schools, and this is the reflection guide that we use. For those of you that are chaplains, you'll recognize this as a CPE verbatim. This is not done as a CPE verbatim. But students, think about a patient that they've just recently seen. How were they affected emotionally, spiritually, humanistically? You know, what was uniquely spiritual or humanistic about what they did? And then, did anything get changed? Were they changed at all by that encounter? We are all changed by our patients. We may not be consciously aware of it, but we're in relationship. And so our thematic analysis of all of these schools was the sense of transformation. All the students identified with something about change and being changed. Awareness of their own spirituality, their call, the importance of doctor-patient relationship. But also what surprised us, we did not expect this, was the relationship with their mentors and their peers, and this notion that they felt a community had been built in these rounds. And on the quantitative survey, less burnout and greater empathy. So at UCLA, this is now integrated through the full 4 years. So how to teach compassionate presence. Art Lucas, a very well-known chaplain leader who died many years ago, pancreatic cancer, and this is his slide. And 2 weeks before he died, I said, you know, I've been using it. Is it okay if I use your slide? I just need so much. He goes, please use it. So I do integrate it. He's another one like Rosemary that has impacted my life a lot. And he talks about presence as the confluence of narratives. Sitting in the center with another as a caregiver and patient meet, as one hunkers down, is fully present with another. Silence, sitting together. So it's being in the moment, fully attentive, aware of what matters most. So now I understand why Rosemary talked about meeting the Buddha. Because in Buddhism, and that in many types of meditation, but in that particular type of meditation, the observation of the mind and the distractions and our thoughts really is a beautiful way to be in that moment. And it takes a lot of training to be able to do that. But it does help. I recently had an experience with my dad. I visited him, as I do every weekend, and during the week too, but this was on a Saturday. And he was confused and slurring his speech, and I was all in my head, la la la, what's going on? Is this it? You know, hospice referral, non-hospice referral. You know, the whole thing in my head, right? So I took him downstairs. He has his own earbud. I took him downstairs, and it was snowing, and he was looking out the balcony very peacefully. And we just sat there, and I sat in his presence so peacefully. And out of his mouth, he says, you look at the being, feel good deep inside, and then let it go. So I put this up for 2 reasons, to bring us back to what being the beauty of our patients, looking at that beauty, and letting go of all of the other stuff we've been trained to be in that moment. But also to say, as Rosemary said in her video, that all our patients have meaning and purpose and dignity, regardless of their abilities, disabilities, disease, at ease, whatever. You know, all of them. And if we create that space, we will hear who they authentically are, and we will hear incredible wisdom. So I'm going to close with just 2 models, and it's an introduction because I'm actually working on one of them, and it's just a beginning part. But Joan Halifax, my friend and colleague, developed a grace model of active contemplative practice. And she talks about gathering our attention, recalling our intention. Why are we there with that patient, right? Attuning ourselves to ourselves, but also to the other, being aware of what's going on in us, considering what we will serve at that moment, and engaging in ending the interaction. So she, like me, know what it's like to be in these busy settings And we're not going into a monastery or a retreat house to be present with our patient. We're doing it in those busy clinical environments. So I'm a secular Carmelite, and St. Teresa of Avila has had a tremendous impact on me. And so I took the Lectio Divina model, which that was a popularized version of her meditation. For myself, I've been using it this way, and I was actually inspired when I was at the Vatican doing some work on palliative care, and in an encounter I had actually with the Pope. We were staying at his place, and I had sort of just accidentally walked into him. We're supposed to keep a distance. And of course, talk about presence. He kept walking, and one of my colleagues said, you couldn't move, and I couldn't. It was phenomenal. And then I thought more about this, and I thought I will try to explore this more, both in teaching and others. I do this with medical students. But we need to prepare ourselves for this. We have to center ourselves before walking into the room. Lectio, the reading part in the spiritual practice, we're reading our patient when we first see them. What's our sense of them? Are they tense? Are they anxious? Are they sad? And what are they telling me about what they need in the visit today? Or what is in between the words too, right? The meditation, so I really breathe and very focused to try to transition to stillness. If that what is happening, it doesn't always happen, but it's the invitation for that. Then there's that soul talk sometimes that occurs with the patient, and occasionally those moments of profound stillness and connectedness, my words with the sacred and the other. And then we use your intuition to move. This is completed, and you move back to the setting. We have a module in the online course on presence, and one of my medical students who did a palliative care elective with me did that module. He said, I like module 1, I like module 2, but when I got to module 3, I found it to be incredibly inspiring. I felt chills and familiarity with the motivations I brought into medical school. What has happened since starting is an excessive focus on the technical and not enough focus on the sacred aspects of medicine. I look forward to putting this these principles into practice. In particular, I intend to take a pause moment before seeing each patient so as to center myself and become prepared for the sacredness of the encounter to come. We are all incredibly blessed by the people that we walk with on our journeys. And as my dad's healthcare aide says, at the end of my day, he blesses me. There is nothing more holy. And that is what is tending the holy. Thank you very much for your attention. Any questions from the audience? Or comments, experiences? Yes.
I'm really working a critical care unit, and thank you very much for everything you said. There's a huge element of dealing with families. Sometimes patients are way too sick, so everything that you said, in my experience, we have to get through to the family first, because they're there with all their fears and their guilt and their attachment, and we just have to use that technique with the family before you can even reach the patient. And sometimes patients are just sick. I just wanted to comment on that, reflecting back onto all my experiences, and even recently of a young woman passing, and it was me addressing the family, the mother and father especially, of letting go of a young woman, where coming from a deep spiritual place inside myself, I was able to do things more than the pastor, more than the doctors, just, being so present and there with them, and they felt it. If the compassion is really, comes from a sincere, honest place, it's so much more powerful than everything else, because it's raw and it's real.
It's raw and it's real. Thank you. Thank you. Thank you for reminding us about the family. There's a whole community. Thank you.
Thank you for your talk. This was fantastic. I'm a chaplain at Torrance Hospice. Torrance Memorial Hospice. I was just wondering if you have any guidance on or have had an an experience with our language around being able to be present, especially when someone is palliative care or hospice nearing the end of life, and they're using battle phrases, warrior phrases. I'm going to fight this, and being able to turn that, because it's not giving up if you're not going to fight, but trying to tell that to the family or the patient. I'm just wondering your experience with our language. Thank you.
Wow, okay, so a couple things. When, in these, there's several kinds of conversations. In being present and having these conversations, I try not to have a desired outcome. So if the language is, I'm going to fight this, it's sort of in that story that my colleague shared, then that's where that person is at that moment. And for me to presume that I can switch that around, because in my mind, having just met the patient, but I know that stage 4 is stage 4 or whatever, you know. So I try to be, and that's where they are at that moment. And that's what accompanying is. And I think, you know, you know, watching Rosemary with the students, you know, the student was crying, and I knew we were about to end, and my outcome was bringing her to this resolution. And fortunately, I kept my mouth shut. And I learned, Rosemary just said, okay, it's time to end. And when the students came back a month later, and she said, what was this? It was profound to recognize that we can't control everything, that all of life is an unfinished moment. So I use a lesson like that with this. At this moment, I can't change that person's language. That's not what it's about. But I can be there. I can be with the questions, etc. I don't know if that answers you. Yeah. That's where that person is at that moment in time.
Thank you so much. I really enjoyed your talk. You mentioned even the word spirituality can be challenging for people, and as a chaplain, or Kim, just being able to present ourselves, to introduce ourselves to the family and patient is to get our foot in the door. That this is as important as seeing the nurse. So, comment on how to approach that?
Yeah. I cannot stand the question from my colleagues to the patients, would you like to see a chaplain? I cannot stand that question. And all my chaplains colleagues, they go, just don't say that. So would you like to see someone on my team who's really skilled at being present and would be a great person for you to talk to? That's the biggest change that I think we need, and that's one of my other hidden agendas with the ISPIC program, is that I'm hoping the clinicians hear that when the chaplains are saying, you know. My second thing is, and I just hope it happens, but you know, the rest of us on the team don't need permission to go in. The person can tell you they don't want to talk to you, but at least you can go in and introduce yourself, right? But I think we need more chaplains, and it should just be, you know, a member of the healthcare team. Right? And so that's what I would say, but I agree with your frustrations because people box chaplains into clergy.
I'm a nurse, and sometimes I'm looking to have some work that I can try to think of. I say, they're not your permission to be on you, so I would love to be able to remember that.
So not do you want to see a chaplain, but there's a colleague on my team who's trained in deep listening presence, and I think would be a wonderful person for you to talk to.
Oh, hi. My name's Milan. I work in the trauma unit across. One of the phrases I use all the time is, what can I do for you today? But that's so clinical, you know, get another consult, what do you need? Is there like a catchphrase that I could start to use? I know you're saying speak from your heart. Am I just waiting to see what my heart says, or is there like a phrase I can use?
So give me you're in a trauma unit?
I work in a trauma unit, and the phrase, you know, hi, my name's Milan, I'll be your nurse today. What can I do for you today? And they will give me a whole list of what they need. And I'm like, I will do that in 12 hours. I will do my best. So is there an emotional catchphrase I can use, or compassionate phrase.
So I think entering the room with an intention is what will transform, I think it will bring you to that level where people will feel invited to share. What do you need is not a bad question at the beginning. I don't walk into an exam room all zenned out and present in the room, right? I mean, I have to find out where the person, and Joan's model is the same thing. You want to be aware of where the person is and what is the most important need. If someone's having chest pain in my office, I don't do the FACP spiritual history. And so you have to figure out what is important in that moment. But it's your own internal being of where you are. You're committed to that person with all your levels of skill, including that of a nurse. And so you're there to meet them. At some point in that visit, there may be maybe you come back. I don't know all the situations, but you may come back and maybe that person is quiet or something. Then you sit down. Then you offer that silence or that opening question. Tell me more. What's going on? Then you use those from the hard questions. Head questions are fine. I'm saying in those moments, then you start thinking, what is that person really saying? And maybe there's no question needed. Maybe it's your listening presence.
Okay. Thank you.
Yeah.
Okay, my name's Lorena, social worker.
Where's the question?
Over here.
Oh, there you are. Okay, got it. Okay.
How do you discern between using a chaplain and a social worker? Because a lot of this is what we learn and we're trained to do. So when do you make that distinction?
So fortunately, George Hansel will be speaking later this morning. He'll be able to give you even more of an explanation, but the training is different. And I think all of us overlap. I think all of us in this room from all our different professions overlap. Right? But chaplains have different training when it comes, most of them have master's degree in divinity or religious studies or philosophy. Buddhist chaplains have different type, but most have a training in those areas that we do not have training in. So the ability to discern spiritual issues and where the theme might be spiritual. So again, we have to recognize our different training. The other is in presence. And I know last week when I spoke at Cedars, the chaplains talked about being really busy and sometimes frustrated that they can't be present because now they're doing the notes and everything that the rest of us are doing. But they actually do have training in presence. They have some training in spiritual direction. So that's where I think the difference is. It's not that you're not being present. All of us in this room have the capacity to be present, with some training.
We have the training on reflective listening and present, silence, all that stuff.
Right. That's true, but some of the reflective listening I think is a little bit different. My co-mentor is a social worker for my medical school, personal professional development, and we had this exact discussion because each of us are trained in our different specialties, but not quite the same way as a chaplain. Now, having said that, for our reflection rounds training, some places that don't have chaplains have sent social workers and psychologists, and with that training, lots of people can be trained to do that type of reflective listening, but the deeper spiritual work with distress and trying to uncover some of that, there's additional training, different training that chaplains have. I hope whoever George is, I hope I answered that correctly.
We have to move on to our next speaker. Okay.